Welcome to MycoClinics. This is season 3, episode 4, on the 6th of June, 2024. I'm delighted to welcome you to a session on Candida Auris Outbreaks and Endemicity, and welcome you on behalf of the organizing committee and my co-chair, Professor Arnaldo Colombo from Brazil. So the format of this MycoClinics session is really where clinical experts present case studies with diagnostic considerations and processes, treatment deliberations, follow-up, and outcomes. But of course, because our session today is outbreak focused, our speakers are really going to be discussing a scenario, a hospital scenario. They'll discuss the epidemiological investigations, response, follow-up, and then outcomes, followed by a discussion. And we'll then have a 25-minute Q&A thereafter. Just a reminder that the MycoClinics sessions are recorded, and I'll direct you to the YouTube channel. The previous 2 MycoClinics, for example, focused on recurrent vulvovaginal candidiasis and chronic aspergillosis. Also remember to sign up for the mailing list. We've got 2 fantastic speakers today, Dr. Silke Schelenz and Dr. Jonathan Strysko, and they are going to be presenting contrasting views of Candida auris outbreaks from a high-income and middle-income setting, respectively. So just a reminder, before we move on to the session today, just a reminder of the medical mycology trainee seminar series. The next seminar is scheduled for the 13th of July at 4 p.m. British Summer Time. And if you tune in, you'll hear a bit more about the live cells and also bacterial fungal interactions. And then our monthly Myco talks are scheduled every month, of course. And so the last session was just a week ago. The next session coming up in 3 weeks' time on the 27th of June, and then the next session again in July 2024. And then also to highlight the postgraduate certificate, diploma, and master's in medical mycology, hosted by the University of Exeter. The course directors, Doctors Mark Ramsdale and Adelia Warris. As a graduate of the UCL MSc, which preceded this course, I'd strongly recommend this. So I'm now going to introduce our first speaker, Dr. Silke Schelenz. Dr. Schelenz is currently a consultant microbiologist at King's College London, King's College Hospital in London, where she's the laboratory director and clinical lead for infection services. Dr. Schelenz graduated from the Faculty of Medicine at the Free University of Berlin in Germany in 1992, where she also studied for MD in the Department of Pediatric Pulmonology and Immunology. In 1997, she obtained her PhD at LSHDM, studying host response to aspergillosis and cryptococcosis. She's since specialized in medical microbiology, and her clinical and research interests focus on medical mycology, particularly fungal infections in immunocompromised patients. Silke, over to you. Thanks very much. I'm going to stop sharing.
Thank you very much, Nilesh, for the nice for the nice introduction. I'd like to thank also the organizers for inviting me to present here today. It's always a fantastic way to share knowledge and experience, and by the end of my session, hopefully you will gain some insight on how we manage an outbreak in London in 2015. Just need to move the, I'm very sorry, can't see my summer slide. Just 1 second. can't see on the screen. Yeah. So Candida auris is a global threat. And just to complicate things, has now changed its name to Candida auris. But in order not to confuse anyone, I will stick to Candida auris. Many of you will know that the first case was reported in Japan from an ear infection, and then the first candidemia reported in Korea in 2011. And then people started looking back in their collections, these collections, and found cases right up to into 96. But so it's a relatively recently noticed a Candida species. The mortality is prescribed as very high, and particularly during the COVID time, mortalities have even been up to 80%. Outbreaks occur, can be anything from 2 cases or recently up to over 600 cases, like in Italy. And Candida auris has been often in the laboratory misidentified. I'm not going to into details why this has been. It's now much improved. And since the WHO has created their fungal priority list, it also is now on the priority list. The Candida auris is in now present in many countries and over 47. So it's really a globally important fungus. So there has been a simultaneous emergence of Candida auris of at least 4 clades, and now 6 clades described. The most recent ones, a case from Iran, and now also in Singapore, Bangladesh. What's quite striking about Candida auris, it's a multi-drug resistance. Over 90% of resistance are against at least one antifungal, that's fluconazole, but often also ambisome. But it depends what test method you use, because there's some discrepancy on, say, if you use different test, susceptibility test other than CLSI and E-test is not quite so accurate anyway. But there's also been a echinocandin resistance described. Since Candida auris has now been emerged, for the last 2 years, we're learning a little bit about the natural reservoir. It's been found in marine ecosystems, seawater, estuaries in Colombia, wastewater, and even in the ear and oral cavity of dogs. And in one case, also airborne dust in Kuwait. And there is this case where we also see it in salt apples, where we think maybe pesticide treatment from the environment is now moving in as a possible enhancing azo resistance. Now, Candida auris has the propensity to transmit, and that's why we're here this afternoon. Originally, first case outbreak described in Venezuela, causing candidemias, high mortalities, and then followed by Pakistan and India. I was fortunate to visit Pakistan. The picture up here on the top right, it's a dialysis unit in a Pakistan hospital, and it's very cramped, and there's a very high turnover. I said, oh, you can isolate the patients who, before you have a screen, and there emergency you can't screen, there's no screening. And these beds, they tell me, get never cold. As soon one patient has finished dialysis, the next one moves in. So very, very difficult situation, depending in which countries you are trying to control your outbreaks. So then we moved to 2015 when Candida auris hit Europe, and I happened to be the consultant microbiologist in a London hospital, experiencing and having to face the first outbreak in Europe. And I'm going to share our experience. What's interesting is also when you look at data from the US, despite everything we've learned since 2012 about outbreak management and so on, you will see on the bottom right that the case notifications of Candida auris in the US is going up and up and up, and including also cases. So what makes Candida auris so transmissible in the healthcare setting? Well, we know there's a really long persistence in the environment and can survive in desiccated state for more than 4 weeks. So it really is important. It can probably respond to, it's stress resistant to temperatures. We know it grows at very high temperatures, for example. It forms biofilms, can do it on glass, fabrics, plastics, wood. which also explains why once in the environment it can persist. It also can persist in linen. So if you have the same patient in linen and don't change it, and we can't really decolonize, it's not surprising that Candida auris stays around for a long time. So I mentioned the thermal tolerant, and also it's tolerant to relatively high saline, which means, everywhere the sweat points is where it thrives. And that's where the body sites is that we include in our screening. The ability to shed from the skin is key to the environmental shedding and environmental contamination. And then, there's a lack of effective skin decontamination products. And this is up to date from the first outbreak 2012 up to now in 2024. We still haven't really got a good decontamination program for the skin. There are no really effective agents, but I'll talk about it in a minute. It can rapidly transmit as well. In our study, we did root cause analysis and found that patient exposure to a positive environment was as little as 4 hours for the patient to acquire Candida auris, probably from the environment. And it has reduced susceptibility to very common environmental disinfectants. And again, I come to it a bit later. And we also know that, when we first had our outbreak, the ICU and physician said, why don't we give all patient echinocandins? Well, it has no effect on skin eradication, and it increases resistance. And then we had the problem of delayed laboratory diagnosis. I'd like to take you to 2015, when we had the first outbreak in Europe in a London hospital. This is a relatively wealthy hospital. It's a cardiothoracic specialist center. It had one of the 5 ECMO centers in the UK. And I did regular ward rounds. I was as a microbiologist on the ICU. I looked at all the isolates. And this was a 20-bedded unit. And on one of the occasions in April 2015, I found one case, 60-year-old male, constrictive pericarditis on ECMO with a sternal wound with a Candida auris. So I had to look actually in the literature. I was not very familiar with this yeast, didn't think much of it, but took note. Then a second case occurred, it was in the same months, a female in a sort of mini isolation in the same ward, again, Candida auris. This patient had a coronary bypass operation. It was found in the sputum. Both patients not infected, but it was unusual. And then a couple of months later, 2 more cases, at which point I wanted to hold an outbreak meeting, but nobody was interested. Nobody did know, had never heard of the pathogen, and I had trouble getting people interested. It took several months later, when we had our first candidemia, that we then been able to hold an outbreak meeting. And at this point, we also had a Klebsiella CPE outbreak on the same unit. And we had our outbreak meeting, and we thought, well, what should we do? There's nothing published on how to contain this outbreak. So we applied what we knew about CPE outbreak measures, infection prevention control measures. So we put positive patient in isolation. Now we had a couple of more, we cohorted them, and we used chlorhexidine to try and decolonize the skin, having no idea whether this agent would be actually active or not. We also traced contacts of the patient who were positive. And while they were being screened, we isolated and cohorted those, and we screened the nose, axilla, groin, throat, the urine, and rectum. And don't forget, at this point, we had no evidence which side to screen, no idea. And we thought, well, if there's 3 negative, then we could de-isolate them. And we used positive personal protective equipment, and you can see here the trolley, which the long gown sleeves, aprons, just as our CIE UK policy. And then once the patient's left, we did terminal clean with chlorine products. Great. The Klebsiella outbreak went in a flash. But I'll show you in a minute what happened to the Candida auris outbreak. In the meantime, we had to also deal with these increased candidemia and sternal wound infections, which really were concerning us. There was no guidance on how to treat, so we applied European guidance on candidemia. We used first-line echinocandin, and if that was say not possible, then second line amphotericin plus 5-FC, and we use beta-glucan monitoring. And we had candidemias even in patients who were not even colonized. The first time we knew they had Candida auris, they had a candidemia. So what did we do to manage these infections? Because that really was of our concern. We treated them with echinocandins. And I want to just show you one case which illustrates the really scary bit about Candida auris, which can develop multi-drug resistance on treatment. We had a patient who had was colonized with Candida auris in the sputum, but had anidofungal exposure due to some empirical treatment of pancolitis. And then suddenly I had a positive blood culture, which was just resistant to fluconazole. We treated 14 days with amphotericin 5-FC. And then when we'd say take the lines out, we had a positive line tip, and that was pan-echinocandin resistant N5-FC. So developed it on treatment or on exposure, following exposure of antifungals. When we did whole genome sequencing, we found the ERK11 mutation, which is very common, and then also described a fluocytosine for one mutation in FKS1 echinocandin mutation as well. So it is scary that even on treatment, so we implemented a very strict antifungal policy and antifungal stewardship. So what else did we do? So we implemented good antimicrobial stewardship, including watching which antifungals to use, reducing the use of azoles, for example. And then at the same time in UK, we had a new version of the EPICS-3 National Evidence-Based Guidelines published. These are for preventing healthcare-associated infections. And this is going back to basics. So we call them high-impact IPC interventions. We focused on aseptic non-touch techniques when we put in vascular lines, because we know candidemias in general are often line-related. And we introduced these cloaxidine biopatches around the exit site. We said don't open the wound dressing because it was cardiothoracic unit, because as soon as I opened the dressing to screen patients, they were exposing them to Candida auris colonization. And then we stopped tried to reduce broad spectrum antibiotics as well, and then lots of training and implementation. The good news is, so here you can see our first measures didn't restrict infection at all. The Klebsiella outbreak was finished, but Candida auris went on and on. But we managed with the high impact interventions. We saw no more invasive Candida infections. These are these biopatches, and you will have to imagine there was no evidence published in 2015. And I, as a microbiologist, had to go back in the lab and had to do some sort of what you would now call pioneering studies. And naively, I put a biopatch on a Candida auris subaurus extra plate to see whether there was some sort of inhibition, and it inhibited. So I said, well, okay, we'll do it for all the patients. So we stopped infections, but unfortunately we were seeing ongoing transmission, and it also hit the press by now. It called Japanese fungus spreading in UK hospitals. So it was very scary, and a lot of pressures from hospital management. So how to implement IPC measures when there was no published evidence in 2015? So we didn't know whether it was clonally related. There was no typing service in the UK. We didn't know how it was transmitted. Was there a point source? Was it healthcare workers, equipment, environment? No idea. Nobody knew. We had the CDC global telephone conferences, Pakistan, India, South Africa, and South America. And I was looking for guidance, but I think everyone was just firefighting. We didn't know which body sites were best to screen. We didn't know what to use to decontaminate the skin or the equipment, and there were absolutely no published guidelines at the time. What we did do, we went around the environment and looked whether it was contaminated, and no surprise, this is a typical ICU bed in that hospital in the UK, and we found it everywhere, on all vertical surfaces. We have shared equipment going from patient to patient. We didn't find it there. But when you look at this trolley, this was a typical NHS trolley. We've got a plaster holding in a little battery. How do you decontaminate all these cables and whatever, and a fabric bag? big challenge because these trolleys would go from one patient to the next if not careful. Other studies now have also found that you can have air positive around bed spaces of high shudders of patients. You find it bedrails, chairs, door handles everywhere. So once a patient is positive, they shed it everywhere. And the same is with equipment. We found it in a number of high touch equipment. This is from an Oxford study. They had these temperature probes which they tuck under the patient's arms and were reused from patient to patient. And the same with a pulse oximeter. So not surprising, other studies have found it everywhere else, you know, where you touch these alcohol dispensers, bedpans, everything. So we have high contaminated environment and equipment. The question was, what should we use? What should we do? We went to a sure, clean environment, and this sounds so basics. We engaged with the cleaning manager and the staff. We shared the problem with the cleaners and explained what's happening. But we also had to overcome language barriers with cleaners. We discussed with them what the problem is, and we said to them, look, this is a commode. We're going to use these fluorescent markers on the day where you're going to clean the commode, and then we let you clean. We don't tell you which one we've marked, but we'll come and show with you. We shine some UV light, see whether there's any remnants of fluorescence, which means it's not cleaned properly. So they were so surprised, and it wasn't like policing. It was working with the cleaners together. And they were very taking it all on board. They were horrified to see this. But the surface of these commodes was so rough, it was very difficult to clean. But we focused on cleaning, ordered cleaning equipment, the floors, you know, monitored their technique, use these fluorescent markers. Some other studies explain it. They use ATP environmental surface sampling. And then we use these for what there was I'm clean stickers. So you have equipment, it's cleaned, you put a sticker on. So next person coming along would have some assurance. But the problem is the pitfalls, high staff turnover, understaffing, outsource cleaning companies. And then you will see here from the date of the publications, you know, nothing was published during the time we were all trying to firefight. Only now we get some evidence. So for high-level disinfectants, we now know paracetic acid is very good for using high-level disinfectant. Hydrogen peroxide is effective, but some hospitals have used relied on ultraviolet light, which it really depends on how you utilize it. It's not as effective. When we come to low-level disinfectants, this is the floor cleaning. We use sodium hypochlorite, but we went to up to 10,000 parts per million. And you can smell it on the unit when you came on. It's hazardous for staff to use, but it did work. Some hospitals still use quaternary ammonium, and this is a problem because those hospitals who use it, it's really the least effective cleaning product to use against Candida auris. But unfortunately, there are now some clades already resistant to sodium hypochlorite, which provides new challenges. So as simple as it sounds, we really focused on environmental cleaning, monitor regular assess healthcare environment, remove broken, damaged equipment, broken mattresses, and then we introduced reduced multi-use equipment. We went to single-use items, single-use pillows, single-use bronchoscopes, as much as we can, and that costs an enormous amount of money. We regularly clean and disinfect the rooms, the equipment, the common areas, and every time we used so we used chlor-clean and chlorine dioxide wipes for surfaces and chlorine-based for terminal cleaning, followed by hydrogen peroxide vaporization. And as soon as we vaporize these rooms, we also put in all the cleaned equipment in it on a regular basis, trying to expose these leads that you see in these fine equipments and so on to hydrogen peroxide on a regular basis, just to try and increase the level of cleaning. How do we now manage decolonization with patients? Well, we use chlorhexidine because that's all we know from MRSA and eradication and CPE. But to be honest, patients were persistent colonized despite chlorhexidine, and it's up to now still no effective skin decontamination product. And we just have to presume these patients are long-term carriers. So we know these patients, once they colonize, they shed it into the environment, they shed it, the environment and equipment gets contaminated, and we assume it's healthcare workers' hands also touching patient, touching equipment contaminated, and potentially with poor hand hygiene can transmit Candida auris further. In our study, we had a nurse who had a positive nose swab, and this person was nursing a high shadow of Candida auris. So these healthcare workers, they are more like a victim and getting colonized from the contact working with these patients. But obviously, we need to introduce good hand hygiene. When you look at very old studies here on the right from 1994, we already know healthcare workers' hands can be contaminated with Candida species. So it's not surprising that Candida auris will just do the same. And so hand hygiene was also a very, very important point. We implement the 5 moments of hand hygiene. And don't forget, WHO study shows that the average compliance in an ICU unit on healthcare workers in hand washing is less than 60%. So, and this is just not good enough. And the medical director was writing at the time to every single doctor, so saying it's mandatory training of hand hygiene. So we improved hand hygiene. You can use machines. This is a video recording machines of technique, and you can pass or fail. We use alcohol-based sanitizer, mandatory training, audit to compliance, and you need to be up there and audit the practice. You need to be on the wards to make sure that things are happening. PPE use and so is done appropriately. So the best product is alcohol-based products. And then interesting studies, triclosan is now too toxic and it's banned in the States, but there's a compound octanidine, and there's some good work from Austria showing it has really good activity against other Candida species, and there's also some evidence against Candida auris. So question is, maybe we should use octanidine also for patient decolonization. It's often used for MRSA decolonization in babies, and it's very safe to use. But coming back to our outbreak, implementation of IPC measures was drastic. We opened an old HDU unit and recreated an adult ICU on a different floor, restricted access, only dedicated staff, no cross-nursing. Even doctors who nurse the patients who have Candida auris were not allowed to then leave and look after other patients who were not positive. And we restricted visitors and staff movement. We introduced very expensive single-use items, bronchoscopes, pillows, as much as we could. And management was constantly questioning what's the evidence. We also, in this trolley here, you see there's a lot of equipment. So if this is in this one single room, heavily contaminated with Candida auris, we just chuck everything away. We had to throw everything away. Enhanced cleaning 3 times a day, handwear, hygiene awareness, and formal outbreak meetings, and so on. So, and then we had completely refurbished our ICU unit, extremely expensive. You can see there's wood around here. So in these units, there were wooded materials, floors was often broken. And so after the refurbishment, this is what it looked like, nice and shiny. We created more side rooms, removed wood, smoother surfaces that can be cleaned, decluttered it, and minimal equipment in corridors. So, well, the enhanced IPC measures and high impact intervention stopped the infections, and the outbreak came almost to a stop until we suddenly saw a blip. And because of whole genome sequencing, we were able to actually prove that this was a new introduction of a completely new isolate. But I just want to say the value of whole genome sequencing, which we didn't have access to at the time, at the beginning of the outbreak, wasn't there, but is really important. There is something called the pathogen watch. If you are able to type do whole genome typing of your Candida auris strains, you can tap it into this database, and it will show you which clade it is and whether it's related to any of the isolates from your area, if people put in the genome sequence as well, and also whether it was related to some other country cases. So it is quite useful. So coming back to this secondary introduction of a different Candida auris was all very quickly stopped the spread, and the outbreak was ended. So we had 72 cases over 20 months and no more cases after this. I must say we wouldn't have even identified the Candida auris if we didn't do routine surveillance and ID every Candida from every non-sterile site on this ICU, which was a practice long before I joined that hospital, because they wanted to predict what's on the skin or exit sites for bacteremias as well, and other infections. So the impact had also impact on cost. The day-to-day running of the clinical service was compromised. There was bed closure, cancellation of admissions and surgery, really drastic, and management clearly not happy for obvious reasons. And it costs a lot of money. And I can't stretch it more. The communication between management, healthcare workers, and everyone else involved is really important. And it didn't take long for the headlines hitting the New York Times saying Candida auris, a fungus nobody wants to talk about. I'm so pleased that we're here today to talk about Candida auris. What's happened since? Experts have come together and created some guidelines. There's not enough time to go through it, but you can stop and review this presentation online and go through this. We provided some sort of best practice of what to do if you had a single case versus when you're in outbreak, and if you have the resources. And we will hear in the other presentation what to do if the resources are not as plentiful. There are now since also many guidelines published by many countries, and this is a growing list, so I'll leave this up and you can see all the references at the bottom. And to conclude, really, it's an extremely transmissible pathogen in healthcare settings. Early detection and speciation is really important. Environment gets easily contaminated. It's a real risk for transmission. There's a need for isolating patients and to do screening, have a screening policy, enhance RPC measures with it's a high impact interventions that really stop the infections. And then you need to implement good cleaning and be there on the board to observe practice. Many people tell me, yeah, we've implemented this, but if you really go on the ward and stay there and just quietly observe the use of gloves, hand washing, and it's an eye opener. And you see so many times that it's not complied with good practice because it's just very busy environment. It's resource intensive and very costly, and there's a need for good communications. Thank you very much.
Thank you, Mary, very much, Dr. Schelenz, for the outstanding presentation, comprehensive review. It's a great pleasure and honor to me to be here and co-chair this section with Nellis Govender. And I would like to introduce to you our next speaker, that's Dr. Jonathan Strysko. He's a pediatrician and infectious disease specialist. He's assistant professor at Children's Hospitals of Philadelphia, but nowadays he's located in Botswana. In Botswana, he's a consultant of the Princess Marina Hospital and a lecturer at the University of Botswana Medical School. He's head of a CDC-sponsored program of survey of healthcare-associated infections and microbial resistance in hospital in Botswana. Welcome, Jonathan. The floor is yours.
Thanks, Arnaldo. Hi, everyone. I am really honored to have this opportunity to share with this group today. As Arnaldo said, my name is Jonathan Strysko. I'm a pediatrician and epidemiologist affiliated with Children's Hospital of Philadelphia, but I've been based in Botswana for the past 5 years, working clinically at the country's largest referral hospital. I also teach at the medical school and lead a CDC-funded program to build capacity for AMR surveillance. I'll first start with a few disclaimers. First, I have no conflicts of interest or financial disclosures to make. Also, I've included some photographs of our neonatal unit, and photos of our patients and staff were taken with written consent from both patients and the institutional approvals. I ask that you kindly refrain from taking screenshots or sharing them beyond the content of this meeting to preserve the intention with which these individuals agreed to have their photographs used. Finally, I'd like to say that not only do I not consider myself a mycologist, I'm not even a microbiologist or an infectious disease specialist. I'm a general pediatrician and epidemiologist. And so just consider me an honorary fun guy for the day. I'm still learning. For example, I was today years old when I learned that Candida auris has been renamed Candida auris. So if you hear me misspeaking about mycology or about any other aspect of this, please do raise your hand. I'm more than happy to be corrected. This slide is probably redundant now for this crowd, but we all know about Candida auris, that it was identified in 2009, and now with thousands of reported cases from over 40 countries across 6 continents. We all know the features of Candida auris that make it so challenging, its hardiness and its ability to colonize patients and persist in the environment. Multi-drug resistance is common, with most isolates found in Africa being resistant to fluconazole and some resistant to amphotericin and echinocandins. And thus mortality in patients with Candida auris infection is high. We also know that misidentification is common, especially in resource-limited settings. For example, in Botswana, we have no multi-top in country, so even when labs suspect they may be identifying something that might phenotypically look like C. auris, we can't really confirm it because even using automated systems like Viatech and Phoenix, which our hospital only gained access to last year, misidentification is still common. Prior to when we decided to open Pandora's box in 2022 and look for Candida auris, it had not been reported from Botswana. Yet we knew that in neighboring South Africa, Candida auris had been circulating now for well over a decade and had been detected in over 100 hospitals there. And what was especially concerning to us, to me as a pediatrician, was that there were now reports of Candida auris becoming a problem in the neonatal population. The CHARM team at NICD in South Africa last year published their report of an ongoing outbreak in the country's largest neonatal unit, which started in 2019. They found that neonatal isolates were almost exclusively comprised of clade 3 Candida auris, which was almost universally resistant to fluconazole, but about 2% resistant to ampho B. Oops. Here we see the impressive epi curve from the first 4 years of this outbreak, during which time 208 Candida auris infections were detected in hospitalized neonates. Given this background, we wanted to know what was going on in Botswana. In 2022, our team started conducting point prevalence surveys in the 8-bedded adult ICU and 33-bedded neonatal unit at the largest government referral hospital in Botswana. We had recently started conducting surveillance for multi-drug resistant gram-negative organisms there, including extended spectrum beta-lactamase producing Enterobacterialis and carbapenem-resistant Enterobacterialis, using a chromogenic media which was selective for these multi-drug resistant organisms, which meant that it suppressed the growth of drug-sensitive organisms while providing nutrients for growth of drug-resistant organisms. Species identification can be made on the basis of colony morphology and color. Every 2 weeks, we swabbed all inpatients in these units, swabbing periumbilically and perirectally. And in addition to plating on ESBL and ESCRE and CRE culture, we decided to use a chromogenic media purported to detect Candida auris. This chromogenic media provided a color guide to help identify Candida species by colony appearance, and not long after we started screening for colonization, we found what looked to be a Candida auris taken from an ICU patient's skin. On the left, you can see blue-green colonies suggestive of Candida albicans, while on the right, our team noted a characteristic white colony with a blue base suggestive of Candida auris. Over the next 12 months, we tracked colonization prevalence of Candida in our ICU and compared it with the incidence of candidemia, trying to determine how prevalent Candida auris truly was while also trying to see whether the prevalence of Candida auris colonization was foreshadowing outbreaks of Candida auris bloodstream infection. Keep in mind, this is an 8-bedded ICU, and we're collecting swabs every 2 weeks, so there is some redundancy of patients from sampling event to sampling event. Here you can see a couple of things. Superimposed upon the green census level, you can see in pink the overall Candida colonization prevalence. You can see in light blue the prevalence of this surveillance period, but then steadily increases during the first half of 2023. In June and July of 2023, we have our first cases of Candida auris bloodstream infection depicted in the lighter shade blue histogram bars. And presumably due to shedding from those patients with active infections, Candida auris colonization increases, becoming one of the most dominant colonizing Candida species by the end of 2023. Meanwhile, in the neonatal unit, Candida auris colonization prevalence was comparatively much lower, but we did detect 2 neonatal Candida auris bloodstream infections during this time. Something a little intriguing here is the almost 1-year stretch we went without any cases of candidemia and a dramatic spike of cases at the end of 2023. I'll come back to this in a second. Now, before we read too much into our Candida auris situation, which we were basing on the evidence of chromogenic media results, we needed to be able to confirm that these cases were truly Candida auris with greater confidence. For this, we knew we needed to phone a friend, and in this case, our friends were just a few hours away in Johannesburg at the National Institute for Communicable Diseases, South Africa's National Public Health Lab. Their group was generous enough to run all of our Candida isolates, which we had been preserving from clinical infections and colonization screening, through MALDI-TOF analysis, which provides a gold standard identification. They also had an interest in understanding phylogenetic analysis of these fungal isolates to better understand regional distribution of Candida auris lineages. During the surveillance period, we detected 70 Candida bloodstream infections across the hospital. This meant that Candida was overall the 6th leading cause of bloodstream infection hospital-wide. Of the 43 bloodstream isolates we managed to save and send for confirmation, Candida albicans was unsurprisingly the most common species identified, but somewhat alarmingly, Candida auris scooped 2nd place, accounting for 17% of all candidemias. There was a difference in this breakdown by neonatal versus non-neonatal samples. Among neonatal candidemias, Candida cruzae was the leading cause, and we detected 2 cases of Candida auris candidemia in neonates. I'll come back to the Candida cruzae situation in neonates in a second. In looking at this breakdown among colonization swabs, we see Candida albicans being the most common Candida to colonize both ICU and neonatal patients, but Candida auris is a close second among ICU patients, accounting for 32% of all colonizing Candida isolates. I don't have any sequencing data to show yet, but NICD was able to provide information on antifungal sensitivity for our C. auris isolates using Sensititer Yeast 1, which is a kind of broth dilution method, and amphotericin B tests. They found that applying tentative CDC breakpoints, all 21 C. auris isolates which were tested were resistant to fluconazole, and 1 was resistant to Ampho B. And so judging from the sensitivity pattern, it's not unlikely that these isolates will be assigned to clade 3. In terms of how the chromogenic media performed in relation to MALDI-TOF, the sensitivity was reasonably good at 82% and specificity was 73%. And that accuracy improved over time as our lab team got better at identifying which colonies were morphologically more likely to be C. auris. Thus, our takeaway from this is that this chromogenic media was and continues to be a feasible tool for screening, particularly when considering that it is considerably cheaper than PCR-based detection methods. Now, as I alluded to back in the previous slide, we went almost a year without a case of candidemia in our neonatal unit, and suddenly, around Christmas time, I started getting some calls from our pediatricians in the neonatal unit saying, we've got some Candida infections. By New Year's Eve, we had 7 cases and 3 deaths, and the species implicated here was Cruzae. This was clearly an outbreak, but the question was, where was it coming from? Our first thought was that patients were hypercolonized. We swabbed all patients in the affected cubicles, but found only 1 sample testing positive for Candida Cruzae on chromogar, pictured here in purple. This led us to believe that the transmission pathway was not likely to be due to colonization preceding infection, but rather through direct inoculation. Unfortunately, this was not our first rodeo. We had had other outbreaks which had been linked back to contaminated intravenous fluids, which in our unit are shared among patients. So we pulled all the IV fluid bags that were open and laying out on crash cards, only to find that 2 out of the 6 samples tested positive for Candida Cruzae. All case patients, had received IV fluids prior to getting sick, so this was our likely source. This is now our 3rd outbreak in 1 year linked to contaminated IV fluids, the other 2 being Klebsiella outbreaks. Those working in resource-limited neonatal units will be familiar with this practice of sharing IV fluids among patients. For example, if you have a cubicle of 10 or 12 preterm babies, each baby only weighs about 1 kg, so they need only about a few milliliters of fluids per hour. Meanwhile, you've just opened up a giant 1-liter bag of fluids. You know your hospital regularly runs out of critical IV fluids, so you decide to be frugal and draw IV fluids from the same bag to give to different patients. This works fine until it doesn't, until just 1 introduction of contamination occurs. Fluids, especially dextrose-containing fluids, provide a perfect culture media for nosocomial pathogens. And since these fluids are being directly inoculated into the bloodstream, it provides one of the most efficient ways to cause an outbreak in a neonatal unit. We would love to put a complete moratorium on this practice, and we're actively working with our pharmacists and hospital procurement departments to source smaller preparations of fluids for single use. But in the meantime, we have to provide guardrails for this very risky practice. This includes scrubbing the hub with alcohol, never leaving the needle inside the vial, labeling containers and discarding them after 24 hours, and not sharing fluids which contain dextrose. We've come to realize that almost all of our outbreaks are linked to what we can think of as a kind of 2-hit hypothesis. You first have to have a state of hypercolonization caused by overcrowding and environmental contamination, and then you have an IPC breach. Maybe it's just one healthcare worker not scrubbing the hub, and this is the recipe for an outbreak. Accordingly, we've organized our prevention measures around these components. To prevent hypercolonization, we've implemented decolonization strategies, including routine chlorhexidine gluconate cleansing, which admittedly does very little for Candida auris, but it can reduce colonization with other nosocomial pathogens. Certainly, decongesting wards is critical, as is hand hygiene and reservoir control. Sinks come to mind as a likely reservoir for nosocomial pathogens, but also extremely relevant for neonates is to find ways to support a robust microbiome to competitively inhibit colonization dominance by nosocomial pathogens. This includes exposure to human milk and early and continuous skin-to-skin contact, also known as kangaroo mother care. To reduce IPC breaches, we're working to strengthen our IPC team, which is something we, of course, can't emphasize enough. We're working to improve medication administration safety, trying to source smaller preparations of medication like these 10 ml saline bullets pictured here, to prevent the urge or the need to share vials between patients. We have to try to reduce equipment reuse, or at least be vigilant about cleaning and disinfecting this equipment so that it can be safely reused. And finally, we wouldn't even be here telling this story if we didn't believe that improving lab capacity to detect these infections is critical. So we need to be advocating for capacity building at hospital labs and regional and national public health labs to better detect infections like Candida auris. We also need to be strengthening our infection control teams to function as hospital epidemiology teams, to be able to detect and respond to outbreaks in real time, to create line lists and Gantt charts, to be able to detect and to identify reservoirs and transmission pathways, and to really have a seat at the table of hospital administrators and Ministry of Health leadership to shine a light on these critical issues. In conclusion, we are not only reporting Candida auris in Botswana for the first time with cases of both colonization and bloodstream infection in both neonates and adults. We've shown that it is the second most common colonizing Candida species in our ICU. The Candida auris we have in Botswana is likely clade 3, judging from its universal resistance to fluconazole, but relatively good sensitivity to Ampho-B. Candida auris colonization prevalence appears to be temporally associated with infections, and chromogenic media appears to have fairly good sensitivity and reasonable specificity for C. auris detection, making it a feasible screening strategy for settings like ours that lack laboratory resources to detect C. auris using standard methods. In collaboration with Ministry of Health, we plan to move from a point prevalence survey model to an admission screening model as a sustainable way to detect and contain C. auris in our healthcare facilities. Outbreaks of Candida are likely to follow a two-hit model, resulting from a combination of hypercolonization and a breach in IPC practices. Thus, units and settings like ours must adopt a two-pronged approach to prevention, exploring ways to reduce the burden of colonization with nosocomial pathogens in hospitalized patients, while doubling down on adherence to infection prevention and control practices. Hospitals in resource-limited settings are often doing much riskier things. There's a lot of equipment reuse, a lot of shared vials. Thus, our IPC teams must be even more vigilant, creating guardrails around these activities and constantly monitoring for adherence. Future work from our group in Botswana and supported by our friends at NICD include developing a national C. auris containment policy and really building the office at ministry where this work will live and be constantly surveilled for. We want to retrospectively review clinical data and outcomes from our C. auris cases to better understand risk factors and outcomes, which we currently don't know anything about. Because of the nature of the surveillance data, we were collecting information about what risk factors these patients had, how many survived, and what they were treated with. So we'd like to kind of create a case series to give us some insights here. We also look forward to sequencing data from NICD to better understand regional patterns of C. auris spread and phylogenetic analysis. With that, I'd like to send a special thanks to, first and foremost, our shared team, tirelessly collecting swabs and diligently plating them and being just as curious as I was to look into this problem, to our hospital IPC team and microbiology lab for their support, and ward leadership and Ministry of Health leadership that is working hard to create the technical expertise and capacity to meet this challenge. Thanks also to Nilesh and his team at NICD. You've not only run our samples, but you've really helped to mentor our team, and for that I'm really grateful. And thanks to all of you for letting me share today. Thanks to the organizers, and I look forward to our discussion. Over to you, Nilesh and Arnaldo.
Thank you so much, Jonathan, for your presentation, and congrats for the wonderful work in combating Candida auris in Botswana. We will start answering questions that were submitted by the audience. Nilesh, could you help us? Silke, welcome again. We have two initial questions for Silke. Maybe we could start for a very interesting question, asking you how to balance the necessary control of C. auris, conducting surveys with lots of plastics, and the commitment with the sustainability of the planet and reducing costs. Good question for both.
Can we rephrase it? I'm not quite sure what, so it's about the use of plastics and.
Yeah, the question is how to balance the necessary survey and all the actions that you mentioned to combat outbreaks with the sustainability of the planet. Yes, we do lots of tests with plastics in the laboratories, and considering we have people from low and medium income countries in the audience as well, is very costly. How to balance.
And single-use items is obviously not the way, to save the planet. That's absolutely true. It's to prevent outbreaks at the beginning, really, to be prepared to have good laboratory diagnostics and to do surveillance. I think surveillance is the biggest key here to try and capture clusters of potential Candida auris cases so that we don't go down this route of outbreaks. But yeah.
Jonathan, please go ahead.
Oh, okay. Well, I was just going to add in our setting, obviously we do a lot of reuse of single-use items, and we lack the guidance on how to do that in a safe manner. I mean, there is very little in the literature in global public health guidance, because it's sort of like if you don't comment on it, maybe it's not happening. But it does happen, and so we and many other neonatal units throughout sub-Saharan Africa are really pushing to get WHO and CDC to put out better guidance for this, for some of these practices, because they do happen. And I think that as that happens, high income settings can lead the way as well to say, look, we know that that hospital waste is creating a very large carbon footprint, and we want to get better at sustainable practices. Now we need to actually understand which things are better to be reused and how to safely reuse them. And thus settings like ours in low and middle income countries can benefit from that.
I mean, it must be a risk-based approach. The definition of single use from a medical legal point of view, it puts us in a very vulnerable position should the patient suffer consequences. So it's a balance, isn't it? Especially when we also think about the recent result from the UK blood products and HIV report that just came out. It's very scary thinking about some of the consequences of exposures.
Thanks, Silke. Thanks, Jonathan. Jonathan, I think many of our audience members will not be that familiar with Candida auris infections in the neonatal population. It's relatively unusual, well, in the global context. Perhaps, I think there were a couple of questions. If you could comment on how neonates present with Candida auris infections, and maybe also Anna's point about to what extent do you think that antifungal prescribing has driven this the emergence of Candida auris in your setting?
Well, Nilesh, I think you're probably better poised to answer those questions. So maybe I'll start, and maybe you can finish up. Certainly, essentially, these patients appear septic, and it's very difficult to distinguish them from bacteremia as well. But usually, you might get a story where they've already had they've been in the hospital for quite a while, and they've had broad spectrum antibiotics. They may be on TPN, may have central lines, and so I don't know of anything particularly, except for maybe some of the lab parameters that might point toward Candida auris candidemia versus other candidemias or bacteremias. Just to point out, in our outbreak, that was Candida cruzi. So that in this 1 year surveillance period, we didn't have any we didn't have any Candida auris outbreaks per se. And I think what was so striking about that was that some of these babies were still in their first week of life, and they were all coming from the same cubicle. And you know, it wasn't the typical story of patients having been there for weeks and having multiple having been on multiple courses of antibiotics. So that was kind of the atypical nature of that kind of made us think that it was an outbreak. Unfortunately, we don't have surveillance on antifungal prescribing patterns. I wouldn't be able to really comment on that. We don't do fluconazole prophylaxis in our setting. And I know that in other places they've abandoned that practice as well, but some places still do it. So yeah, I think that's all I can say about this. But perhaps you might have some additional information from what happened at Botswana.
Jonathan, I think you're completely right. I mean, there's nothing very specific about Candida auris compared to any other type of candidemia in neonates. I mean, some of the laboratory markers may give you a clue. I mean, you know, there's some indication that the beta-glucan levels may be a bit lower for Candida auris than other species, but that, of course, is not a fantastic assay. I'm going to maybe ask both of you, both of you mentioned multi-drug resistant bacterial pathogens plus Candida auris circulating at about the same time. Silke, you and Jonathan, perhaps if you could just weigh in on, how you managed both, both multi-MDROs plus Candida auris simultaneously.
Well, from the data that I've showed, the Klebsiella multidrug resistant organism was transmitted at the same time as Candida auris, which indicates poor IPC practice, poor use of PPE, poor use of hand hygiene, probably patient-to-patient transmission, probably through healthcare workers. So what was striking is that when we applied the UK recommended measures for CPE outbreak control, which is long-sleeved gowns, gloves, aprons, the Klebsiella outbreak came to a halt immediately, whereas the Candida auris didn't. And part of that is because Candida auris, bit like Acinetobacter, can contaminate the environment very easily. So much more than gram negatives. They're more resilient. They've got, biofilm formation, resilience to disinfectants. So, and that is probably, I listed a whole factor set propensities of Candida auris, or that it has in order to sort of promote outbreaks more than gram negatives, really. So, and that is a challenge. So, and when you see this, you really have to be almost on the ward and observe that good IPC practice is complied with, because I can tell you, every time I went to the ward, I could see poor hand hygiene, poor use of gloves every time, despite training. It's a busy environment, sick patients, changing workforce, tired workforce, and that just escalated.
Yeah, I think very similar scenario with us as well. I think the key, as Silke pointed out, is continued surveillance, continued eyes in these areas, so that you can detect when things are starting to spin out of control. And usually when that happens, then you're doubling down on these IPC measures. You are reducing colonization. We had in one of our Klebsiella outbreaks we managed to reduce colonization with ESBL producing organisms by a massive amount with decolonization strategies like CHG and fumigation and hand hygiene and all the outbreak measures that happen. And yet we still continue to see cases coming. And that's when we realized we had contaminated multi-use vials. So that's really what kind of brought that to the forefront. And since then, once we see any sort of increase in uptick in cases, we immediately look to those vials, and it feels like you're just doing the same thing over and over again, because you're like, haven't we gone through this before, and can we stop this really risky practice? But even with all of those measures, like, as you pointed out, the comparison with Acinetobacter, there will be some persistence in the environment. We're looking at ways to remediate our sink drains, and some promising methods that we've used, because we have actually found at least one case of Candida auris identified from sink drains, but reduction in things like Klebsiella contamination of those sink drains, but Acinetobacter is very hardy throughout that whole process, and presumptively to Candida auris if it's if it establishes itself in the environment. So yeah, definitely some parallels there between some of the gram-negatives that we deal with.
Nilesh, may I explore one question that was sent by the audience in terms of the epidemiology of C. auris in both regions? The question is, looking at the full landscape, what is the balance in the hospitals where you have seen reported Candida auris of independent introductions of C. auris versus case or hospitals that started to be infected, reporting clearly link with the transfer of other patients from hospitals that that are facing outbreaks or came from travelers that came from countries that you have reported. And then I would extend to you one reflection, that is, when should I start screening Candida auris in a hospital that have never reported C. auris before? I would like to ask you to comment this balance, and when you start looking for Candida auris in hospital where you don't see outbreaks.
Who do you want to start?
Sure. So in terms of figuring out what is a hospital outbreak versus independent introductions, I think there's not really any good way until we start to do more sequencing and sort of getting those real-time results in our setting. In terms of how to know when to start screening, when to know it's sort of endemic in your facility, what we would love to see, a kind of plan that we have, is to at this point do admission-based screening until we see no more Candida auris, and then basically do some point prevalence surveys on a regular basis, maybe monthly, every 3 months, and then if we see it come back, restart the screening process again. That's a little bit of just making it up, but assume that's probably what others are doing.
Yeah, I mean, I'm now working at a hospital which also had a previous outbreak following the first one we had. And we use PCR for screening of all high-risk patients. So we're screening patients on ICU regularly once a week and hematology, and we're screening patients on admissions from endemic areas or from hospitals that we know have current issues. The question about screening, it's all about prevalence, really, isn't it? If you are in a country or a region where it is very, very uncommon, screening is probably not cost effective. And you could argue it is Candida auris plays at least a big problem in the ICU and where you have breach of skin with lines and so on, like any other candidemia. So these are the that you're more likely to pick up Candida auris in clinical samples as well. When should you introduce screening? I mean, it all comes down to prevalence. And if you have more than one case, I mean, if you have one case identified, I would obviously recommend to screen all, do contact tracing, because we know from our outbreak, contact of 4 hours is enough for transmission. I would cohort all the contacts, screen them as a sort of search and destroy method. It's a bit how we used to deal with MRSA eradication, trying to get numbers down. In the UK, it was really bad, and now it's sort of, it comes to quite a low level. As soon as you've got an outbreak as per definition, or clusters 2 or more, I think you probably want to introduce screening in a sort of like, probably in the unit on a weekly basis, and make sure that patients don't come in. What's really important is the communication. Very early on in our outbreak, we realized transferring patients, we transferred with a whole package, with whole guidance on that the patient was colonized or infected. We provided full IPC support, and made sure that the other IPC team in the referring hospital was aware and had the support and guidance of what we would recommend to do. So communicating positive patient transfer is important. But I do know, like in countries like the States, it's when they move cross regions, it's more difficult to keep the communication up, and also patients may be lost to follow-up, and not necessarily will it be known that they had been colonized. So that is a challenge, have better records. But it depends on resources, whether people have electronic records makes it a lot easier. If it's paper records, makes it very difficult. Empower patients.
Thanks to you both. Can I ask another question? So Silke, you mentioned in your presentation that some of your measures were drastic, draconian. I'm just wondering, what is the minimum that you would need to eradicate Candida auris? I mean, from our personal experience at a large neonatal unit in South Africa, the outbreak continued unabated until that entire facility moved, the patients were moved to an entirely new facility. And that, of course, is not realistic. We were just fortunate that time that we implemented drastic infection control measures, plus the whole unit moved. Just wondering what you think is the minimum to try to get rid of Candida auris from a unit.
Yeah, I mean, when it becomes so endemic in the unit, it's very difficult. I fully agree. And we had to do the same thing. We had to move to a completely different ward and just strip everything. And that's when it becomes expensive. I think in an earlier stage of an outbreak, what the single most important thing is hand washing. It sounds so basic, but we also know that the compliance is so poor, and infection control doctors like myself, we've been struggling for centuries trying to get compliance with healthcare workers. And when I think neonates, they're the least going around, because it can only be healthcare associated transmission. It's the only way they get it. So I think it's good cleaning, basic cleaning with the right products, and hand hygiene would be my absolute basic measure. And it's surprising how many people say, yeah, we do this, but it's the presence on the wards, the auditing. Use your fluorescent marker, it's so cheap. Engage with staff, and then engage and show them what the problem is. And only then, on continuous training and auditing practice, compliance, can you get some assurance that at least that route of transmission is sort of contained. But once your environment is contaminated, you can only move.
Yeah, I
the whole
agree.
Unit.
Really like your three your three hit model. I'm just wondering, would you consider a fourth arm, focused on the environment, just given what Silke said, given that we know that for Candida auris in particular, that's an important reservoir. I know that you included it in your IPC section, but do you think it requires sort of focused intervention?
Oh, yes. Yeah, especially reservoirs, especially sinks. As we venture into this, I'm really trying things out very experimentally in terms of sink remediation and sink maintenance in resource limited settings where you can't just rip out a sink and then put another one in. I think that it's become clear to me how big of an issue this is because of how much interest there is and how little there is, in terms of guidance around this. So yeah, I would definitely pull that out as a fourth arm to really focus on is reservoir control. Yeah.
But we also need to focus on that people not using sinks as sluices.
Yeah.
You sometimes see such poor practice that they hang over like a urine bag to drain or something. It's like there's sometimes this very poor practice that also needs to be monitored. You can see it, from time to time when you visit the units. It's
yeah, absolutely. And I think that's the other. I mean, the other intervention is to remove sinks completely, which I think that you can think about sink placement and remove it from like really high risk areas and stuff like that. But again, it's may not always be feasible. But what you can do is, better set the parameters for how sinks are used. For example, not pouring nutrients down into the sink drain, which is something that we regularly see being done. So I think you need a whole sink bundle approach.
Nelish, may I explore another question? And I mentioned here, I'm seeing anonymous question on echinocandin resistance. And the question is, does echinocandin resistance occurs spontaneously? Then maybe we can explore more first. What are the true rates and prevalence rates of echinocandin resistance? Because fluconazole ampho-B resistant, we see very high rates in different parts of the globe. That's not the same reality for candins. And what is behind? What are the drivers of echinocandin resistance? And some comments on Candiduria by Candida auris and as a potential reservoir for echinocandin resistance. Could we discuss this topic?
So if you want to get started, and then we can all add, perhaps.
I mean, the case that I've demonstrated showed developing echinocandin resistance following exposure. I haven't looked at the whole literature, but I know that, for example, the isolates in Spain, you see this trailing, you see treatment failure. I showed one slide was the Indian strains having high echinocandin resistance, but I couldn't comment what the exact driver is.
Jonathan, anything to add to the echinocandin question?
I don't have anything to add. I don't have any experience with that, so I'll reserve comment.
So, I mean, in general, obviously echinocandins are recommended as first-line treatment for candidemia, echinocandin monotherapy in most guidelines. But I think there's absolutely, there are case reports that resistance can emerge on treatment. And Arnaldo, I think you pointed out correctly, of course, that in certain sort of sanctuary sites where echinocandins don't penetrate particularly well, you can see resistant Candida auris. In fact, when we look at our pan-resistant Candida auris isolates, they're almost exclusively from urine isolates. And then, patients may develop candidemia following on that. There are, of course, levels of resistance. With exposure to echinocandins, you can obviously, the isolate can develop tolerance. You may get resistance and, of course, true fall resistance. So there's a gradation. But certainly in low and middle income countries, echinocandins not really widely available. Certainly in my experience, we tend to use amphotericin B as first-line treatment. So we have a bit less experience with echinocandins, except in our private sector where echinocandins are broadly available.
Yeah, I agree with all your comments. We have some programs in Latin America for offering high-cost medicines for public hospitals, but you are completely right. Most of the hospitals, they may have some limitation in terms of having access to echinocandins. It's interesting to see that there is a kind of time effect in the susceptibility of Candida auris, not just to echinocandin, but also to fluco. If you get the situation in Colombia at the beginning of the endemicity, you may see lots of Candida auris susceptible to fluco, and the situation changed completely after a few months and years. In Brazil, where Candida auris were recently introduced, we believe, Candida auris is fully susceptible to fluco. Can you believe that? We have more than 150 isolates reported, and I should tell you that I have 2 isolates that are resistant. And I believe this is because Candida auris was recently acquired in the environment where we use fungals. But we believe that even that this single isolates is susceptible to Candida auris, if you have a candidemia, you should treat with echinocandin or ampho-B because it will fastly become resistant. And then came a discussion for the epidemiology of Candida auris. I had a conversation with Tom Schiller, whether the hospital may be the source, the amplification, and then the hospital infect the community after having a high burden of colonization, or Candida auris is in the community, is not in the hospital, and then when someone from the community get in the hospital, you have a case that disseminates in an environment where you have lots of invasive procedures, antimicrobial pressure. What do you think in terms of the epidemiology? Both are correct, one, another option?
A lot of thanks for raising that. I mean, I just want to point out that obviously that the different clades are separated by hundreds of thousands, so tens of thousands of single nucleotide polymorphisms, so really are very different. And they do have different susceptibility profiles. As you say, clade 4, which is dominant in South America, has a more susceptible profile, whereas clade 1, the original South Asian clade, is much more resistant. Jonathan presented some data on clade 3, the African clade, which is also relatively susceptible. We only see resistance to the azoles, and a very small proportion of isolates have elevated MICs to echinocandins or amphotericin B. So just to point out that they clearly are interclade differences. And the newer clades which have been described are also slightly different, clade 5 and 6. In terms of the eco-epidemiology, I think Silke might have mentioned this. Candida auris has been found in various environmental reservoirs. What's really interesting to me, though, is the ability for us to now start using wastewater as a way to understand what's actually happening in the, what is moving into the environment, possibly from hospitals. In our experience, we tend to see multi-drug resistant Candida auris coming out of hospital effluent samples. but certainly Candida auris is fairly widespread in the environment, in wastewater at least. So I think that, there probably is going to be a circular movement at some point. People are going to possibly become colonized by Candida auris in, just from exposure to contaminated water or in the environment. And then, like we saw with other pathogens moving from the hospital into the community.
Can I just add to this? I mean, Candida auris, we mustn't forget, is not naturally a colonizer of humans. It's not a natural gut colonizer. So that's really interesting, I find. There's also recent suggestion of in analogy to azole use in the environment and Aspergillus, whether using pesticides containing azole compounds may also contribute to resistance. We've seen it some other Candida species causing outbreaks, which associated with these contaminated apples. Maybe there's also that aspects that we need to consider.
I agree with that. Arnaldo?
No, yeah, that's good comments. Thank you. Thank you both, Nelish and Silke. Perfect.
So just to ask you, I think there was a question in the chat about what are you doing to prevent this from happening again? And I think Andy Borman asked about how many independent auris introductions are you currently seeing in the UK? Do all patients have direct links to endemic areas or overseas hospital stays? So a very specific UK question there.
I mean, once we had whole genome sequence available to us, we could see we had a secondary introduction. But not everyone is sequencing their isolates. It would be good if people were using this pathogen watch or sharing some sort of platform with their sequences, because then you have some idea where patients may have acquired it from, or whether they came from, pockets of outbreaks within their own country.
Thanks, okay. I wonder if anyone's got a comment about what to do when whole genome sequencing is not available, but it isn't in most resource limited settings. Jonathan, you've managed so far without whole genome sequencing. Do you think it's necessary? Do you think it would become more important as Candida auris becomes more entrenched, or hopefully it doesn't, and you get rid of it?
I think there's a lot that we can do without whole genome sequencing, with all due respect, and just in terms of just containment and IPC and whatnot, and building lab capacity. That I would much rather have better traditional microbiology and AST testing before we had sequencing, but I think with time it's going to be more and more common, and I think the model that we have right now, I mean, obviously funding has to support it, but the fact that we have kind of centers of excellence in regions that are generally underserved, that we can actually send isolates to you. I think that's kind of a good way forward. I think that these none of these settings really should feel like as isolated as they are. There are ways to kind of link in, with either South-South collaborations or South-North collaborations to answer some of the questions that you want to have answered that sequencing could answer.
Thanks, Jonathan. Arnaldo, anything else from you?
No, it is almost done. It's 1 hour and 28 minutes after starting. It was a great opportunity for me, I'm sure for the audience, listening once again, Silke Schelenz and Jonathan Strysko. And it was a great pleasure for me to share this meeting with Nelish. And I leave to you, Nellis, to finish the session.
So again, thank you very much to the audience for joining MycoClinics. We look forward to hosting you again in the next quarter, which will start in 3 months' time. But thanks again very much to Jonathan and to Silke, and of course to Arnaldo, and our support team, Jenny and colleagues. Thank you all very much.
Thank you very much. Thank you.
Thank you.